Hi everyone. We are currently in the middle of one of the worst pandemics in history. The SARS coronavirus 2 has left behind a trail of destruction across the world. Several novel therapies are being evaluated that might offer clinical benefit in COVID-19. Chloroquine and hydroxychloroquine, tried and tested in malaria, SLE, and rheumatoid arthritis, has been the center of attention among many investigators considering its antiviral efficacy in vitro. In 2005, during the SARS epidemic, these drugs showed in vitro activity against the SARS coronavirus, which is closely related to the virus that's causing the current pandemic. However, it did not reduce viral loads in animal models, and clinical interest slowly faded away. Chloroquine and hydroxychloroquine demonstrate several putative antiviral properties that inhibit viral replication in vitro. And it's against this background, and considering the pretty much relentless course of this pandemic, that hydroxychloroquine, which is the safer among the two, is being widely used and studied across the world. So let us have a brief look at the evidence available so far on the efficacy of hydroxychloroquine in this COVID-19 pandemic. Does hydroxychloroquine really help kill this deadly virus? In one of the early studies from Marseille in France, Gautret et al. Studied their patients, there were 26 of them, with hydroxychloroquine 200 milligrams thrice a day for 10 days. There were 16 patients in the control arm who were from other centers who did not receive hydroxychloroquine, and these patients were followed up for 14 days. They specifically looked at viral clearance as evidenced by a negative RT-PCR test. And what did they find? On day 3, they found that viral clearance among patients who received hydroxychloroquine was 50%, compared to only 6.3% in the control group. And this trend followed on days 4, 5, and on day 6 they found that viral clearance was as much as 70% in the hydroxychloroquine treated arm, compared to only 12.5% in the control arm. So this study seemed to suggest that viral clearance occurred much more rapidly with hydroxychloroquine. However, there was a major problem with this study in that 6 patients out of these 26 in the treatment arm were not included in the final analysis, of whom 3 required ICU care, probably because they had deteriorated in clinical status. 1 patient died on day 3, 1 patient left hospital on day 3, and treatment had to be stopped in yet another patient because of nausea. So these 6 patients were not included in the final analysis, creating a strong bias. In a subsequent study from the Renmin Hospital in Wuhan, China, you might remember that this whole pandemic arose from Wuhan several weeks ago. And in this study, this was a proper randomized control study in which they used hydroxychloroquine in a dose of 200 milligrams twice a day for 5 days in 31 patients, while the control arm also included 31 patients. What did they look at? They specifically looked for clinical improvement with the use of hydroxychloroquine in the time to normalization of body temperature, which was less with HCQ, 2.2 days versus 3.2 days. The time to relief from cough was also significantly less with the use of hydroxychloroquine, 2 versus 3.1 days. And furthermore, of interest was that on CT imaging, they found that resolution of consolidation or improvement in consolidation was significantly more, 80.6% versus 54.8% in patients who had hydroxychloroquine. So this study again showed that hydroxychloroquine may not only improve clinical symptoms, as in reduced temperatures, reduce the time for amelioration of the cough. In addition to that, it might help improve the extent of consolidation on CT as well. A subsequent study from France by Moline et al., they tried to draw inspiration from the initial Gautret et al. Study from Marseille, and they also were looking specifically for viral clearance or early viral clearance with hydroxychloroquine. This was not a controlled study. They just studied 11 consecutive patients who had comorbidities in the form of obesity, solid cancer, hematological cancer, and HIV infection. They used pretty much the same dose of hydroxychloroquine as the initial Gautret study did, which is 200 milligram thrice daily. 10 out of 11 of their patients had fever and had hypoxia requiring oxygen therapy. By day 5, one patient had died, 2 deteriorated and had to be transferred to the ICU, and one patient developed prolonged QT interval. And when they looked at the RT-PCR, they found that after 5 to 6 days of treatment, the RT-PCR was still positive in 8 out of those 10 out of the 10 patients, one patient having died. So this study, the results of this study, although a very small cohort, suggested that they could not reproduce the findings of the first study from Marseille. Yet another Chinese study, which is available only in the abstract form by Song et al., was a randomized controlled study. On the intervention arm, they used hydroxychloroquine 400 milligrams per day for 5 days and compared it with standard care. And they found that by day 7, the viral clearance was pretty much similar between both groups. And they also did not find any difference in the time for normalization of body temperature, nor did they find any difference in the progression of lesions on the CT scan. Now we come to an 80-patient uncontrolled study from the same group from Marseille, Gautret et al., who came up with the first study which showed rapid viral clearance. So in this study, they combined azithromycin with hydroxychloroquine, having observed in their first study that addition of azithromycin augmented viral clearance. So the dose of hydroxychloroquine was the same as they used in their first study, 200 milligrams thrice a day. Azithromycin was administered in a dose of 500 milligram on day 1, and subsequently they administered hydroxychloroquine in a dose of 250 milligrams from day 2 to day 5. And among these 80 patients, 15% required oxygen therapy, 3 patients required ICU care, and 1 of those patients died. He was an 86-year-old man. So the mortality was only 1 out of 80. And the mean length of stay was 4.6 days. So this was the profile of these 80 patients. And what was the finding on RT-PCR, the viral clearance, which is what they were focusing on even in their first study? They found that the RT-PCR, viral clearance in terms of RT-PCR became rapidly negative. And by day 7, 83% had tested negative, and 93% had tested negative by day 8. So this seemed to augment the initial conclusion that hydroxychloroquine may be helpful, particularly in terms of rapid viral clearance. So at the end of all that, with the evidence that we have at this point of time, do we or do we not administer hydroxychloroquine to our patients with COVID-19? As we saw, there is conflicting evidence regarding the efficacy of hydroxychloroquine in COVID-19. As always, there are believers and there are non-believers. Some argue that there is no harm in trying out a drug with a proven safety record when you're up against the wall with a deadly disease. However, hydroxychloroquine may not be entirely benign, as we all know, with the possibility of QT prolongation and serious arrhythmias. You would need to do regular magnesium and potassium levels, and this kind of care with constant regular monitoring of electrolytes, repeat ECGs to ensure that the QT interval is pretty much within normal limits, can only be done within a hospital setting. There are many studies that are going on as we speak. 3 control studies outside of China, which are listed on clinicaltrials.gov, which will assess hydroxychloroquine or chloroquine for the acute treatment of COVID-19. And the largest of these studies is a phase 3 placebo-controlled trial with anticipated enrollment of 1,300 participants conducted by researchers at the University Hospital Angers in France. So we would eagerly wait for the results of this study. Until then, it depends pretty much on clinician judgment as to whether you would use hydroxychloroquine or not. Hopefully, we will have some positive results within the next few weeks. Thank you.